Thank you so much for being here. So today we have Dr. Alex Wong. So Dr. Alex Wong is the professor of Department of Surgery. He's the chief of the Division of Plastic Surgery, interim chief, Division of Dermatology for City of Hope National Medical Center and the Beckman Research Institute. So Dr. Wong is also the adjunct clinical professor of surgery for the Division of Plastic and Reconstructive Surgery of Keck School of Medicine of USC. And he's also a dear advisor for Wound Reference. So thank you so much for being here with us today, Dr. Wong.
My pleasure.
Fantastic. So we're going to be talking today about lymphedema and radiation-induced cutaneous damage and soft tissue radiant necrosis. So we have prepared a series of questions here. Would that be okay, Dr. Wong, for us to kind of get started with some lymphedema questions?
For sure.
Wonderful. All right. So would you please start out by elaborating a little bit on the role of the different specialties in lymphedema management and also maybe how care should be coordinated for best outcomes?
Sure. Thanks, Dr. Song. That's a great question. Lymphedema, as you know, is a really challenging disease process that affects millions of individuals. And we're getting better and better at taking care of this disease in these patients, and yet there's still opportunities to do better. In my institution and my previous experience, I've found that a multidisciplinary approach to treating these difficult patients leads to best outcomes. And this includes a conversation between really the first line people, the lymphedema therapists, who often are housed in the departments of occupational therapy, as well as medical physicians that manage lymphedema patients that may have comorbid conditions, basic and translational researchers that can advise us on cutting edge therapies for lymphedema, as well as surgeons and microsurgeons that are expert in offering surgical treatments for lymphedema. And so it's really this interaction of the whole team that allows for best practices. And I'm happy to have been involved in this when I was at USC. And now that I've moved to City of Hope, we have a similar construct to do this. And so frequent communication is key, just like for all sorts of other complex diseases, so that there's a good conversation to provide best care and individualized care for every patient that comes through the door.
Wow, fantastic. It's a really, truly comprehensive system that's needed in order to treat lymphedema patients. And then so amazing that you have the Center of Excellence that you set up at both the USC and City of Hope. That's really impressive. Thank you. Now, lymphedema is a complex condition, right? So would you mind elaborating a little bit on the pathophysiology of lymphedema? Also, would there be any strategies to prevent post-surgical lymphedema?
Sure, Dr. Song, these are great questions. And understanding how lymphedema occurs really provides opportunities for us to intervene and treat the process of accumulation of fluid, as well as any wounds that accumulate or result from a patient that has lymphedema. And so I've spent perhaps the past decade trying to understand this really difficult condition. And to me, it obviously starts with some sort of lymphatic injury, whether that is injury by a surgeon who is trying to eradicate cancer and removing lymph nodes, all of them or just some of them. It could also occur from radiation. It could also occur from surgery in the area of a lymph node basin. And these are etiologies for lymphedema to occur in the United States and most developed countries. That being said, lymphedema is probably more prevalent in countries that are at risk for infectious causes for lymphedema or filariasis. And that's actually a much bigger population. I would say, although the root cause is similar in that lymphedema occurs from damage to lymph node basins that prevent adequate drainage from either an arm or leg or another part of the body. Indeed, people can actually get lymphedema of the head and neck if the neck and cervical nodes are destroyed or damaged. And so really the root cause is injury or disruption of lymphatic flow. And when that happens, there's a critical disruption such that if enough of the lymphatic flow channels or the lymph nodes are destroyed to the point where the fluid accumulates and just can't be drained appropriately, This then results in a backflow of lymphatic fluid. And while it normally is collected by lymphatic collectors at the distal parts of our extremities and then shuttled proximally towards the lymph node basins and then eventually to the core and into the thoracic duct, if at any point this is disrupted, then you have lymphedema. And lymphedema is a swelling of the soft tissues. It's characterized by interstitial fluid that shouldn't normally be in the interstitium because there's backflow. And so that interstitial fluid really is almost a foreign body, in my opinion. Our interstitial tissues or our immune surveillance capacity doesn't normally expect to see the lymphatic fluid. And to me, the lymphatic system is like a garbage collecting, a very important garbage collecting system, such that the flow gets back to the core and the damaging or foreign substances can get eliminated or even acted upon by our immune system early. And so whenever you have this foreign substance or lymphatic fluid that is in the interstitium, this actually results not only in just a swelling, but that incites an inflammatory response. Our systems are not accustomed to seeing this fluid, and therefore an early response to lymphatic disruption or lymphatic backflow is an inflammatory response. It can be redness, pain, swelling, and all those things happen early on. As that progresses for days, weeks, and months, then what happens is, and so I'll take one step back. At that early stage, it's the point where lymphedema can be potentially correctable, meaning if you have aggressive compression, good elevation, that can allow enough channels to bring the fluid back so that your body can remove that interstitial fluid that shouldn't be there. And so if you can do that effectively, you can keep quote unquote lymphedema at bay and have it not progress. But if the fluid overrides the system and you have fluid such that your body just can't remove it from where it shouldn't be fast enough, then that inflammatory response progresses to a more advanced stage where the inflammation actually starts breaking down the good lymphatics. And so while you may have a subset of lymphatics that don't work, now with this chronic inflammation, it's not selective. It'll damage everything. It'll damage the fat, it'll damage the blood vessels, the veins, the lymphatics. And so that damage now makes it even worse, so that you're further crippling an extremity that had some marginal drainage. And now that you've taken out and destroyed other lymphatics in the area, you've further disabled the lymphatic drainage system. And at that point, now you're just making things worse. Chronic inflammation, this proceeds through a cycle where your body tries to respond, but ultimately, if it can't, you get adipogenesis, and that's where you have accumulation of fat tissue due to lymphedema. And then ultimately, as you get to later stages of lymphedema, 3 and 4, what you'll notice is that these patients have very firm and fibrotic limbs because the chronic inflammation has ultimately resulted to an end stage of fibrosis. And when you're at fibrosis, this is a really challenging stage to treat. As many of you know, there's really no turning back once you hit that stage. And at that point, and perhaps even stages before that, you're at risk for critical wounds that can be associated with infection. Infection combined with lymphedema is a disaster, needs to be treated with local as well as systemic antibiotics in some instances. And that combination of multiple reasons for inflammation just makes the whole extremity worse and makes wound healing difficult. And then another thing I didn't quite mention was that when your lymphatic system doesn't work right, it does alter the immune status of the entire limb, and such that if you have a wound trying to heal in a lymphodematous extremity, it's just not normal, as all of you know. The immune system doesn't work correctly, wound healing doesn't work correctly, there's chronic inflammation, and as we all know, chronic inflammation blocks wound healing because you need to overcome and resolve wound inflammation before you can go to the path of regeneration, epithelialization, and remodeling. So it's just a challenging disaster that our body has to endure. But in a nutshell, that's probably a long-winded explanation, but that's how I think of lymphedema.
It's fantastic. Thank you so much for taking us through this journey of how the lymphedema pathophysiology happens, because there's so many things that happen before you get to the final stage. And then the way you depicted each phase, it's really didactic. So I really appreciate you kind of walking us through all this. It's fantastic. Now, in terms of the post-surgical lymphedema, right? So like if you, is there any strategy that a surgeon can think about, in terms of preventing or try to minimize post-surgical lymphedema?
Sure. Yeah, thanks for asking. I think this is a great opportunity for us to think about. Whenever lymph nodes need to be removed for usually cancer, it's not a surprise. So we know it's going to happen, and it does provide an opportunity for individuals trained appropriately to intervene. And as a plastic surgeon and microsurgeon, I am trained, and others around the country and world are trained to do immediate lymphatic reconstruction. And what that is, it's deemed and given a couple acronyms. It was first called a LYMPHA, and it stands for lymphatic microsurgical healing approach. And others have coined the term ILR, or immediate lymphatic reconstruction. And they're essentially the same thing. And what happens is after the oncologic surgeon removes lymph nodes, the reconstructive or plastic surgeon and microsurgeon comes in, gets oriented to where the lymphatic injury occurred, identifies cut ends of lymphatics in the extremity. Let's just assume it's a breast cancer patient. And so this would be the medial arm where there was some cut ends of lymphatics before they get to the lymph nodes. And then under a microscope, these very small sub-millimeter lymphatics are identified with the help of contrast agents, such as fluorescein or indocyanine green or lymphozurin blue. And when you identify the cut ends of these, they can then be intussuscepted or put into adjacent veins of similar size, so that normally these cut ends would literally just leak lymphatic fluid, and under the microscope you can see that. They just leak lymphatic fluid, and our prior management of that was just to put in a surgical drain and hope that that just stops and seals off. And really that just results in scar and inflammation. And so the immediate reconstruction approach takes those cut ends, which are draining lymphatic fluid, and gives that fluid a place to go. And it goes to a nearby vein that has a low resistance to it, such that the flow can actually go into the vein. And sometimes you can take 2 or 3 lymphatics, which are, again, about a millimeter or less in size, and you can put several into one vein, because typically there's a big mismatch. Most veins are bigger than 1 millimeter in size, although some venules are that small. And so we'll put 2 or 3 lymphatics into a vein that's about 3 millimeters in size, and this is all done under the microscope, and it takes about an hour to hour and a half extra. But there is some pretty clear data out there where there is very solid retrospective and soon to be prospective data looking at this type of preventative surgery. And given the average rate of lymphedema after a full axillary lymph node dissection for, say, the treatment of breast cancer, that takes the rate down significantly. The typical rate of lymphedema formation in most centers is somewhere in the order of 25 to 50%. And based on some fairly robust series, that can reduce doing this lymphatic microsurgical reconstruction can reduce it by 5 to 6-fold, therefore taking it down to a single-digit risk for lymphedema of 5%. And it makes sense. You're giving the fluid a place to go. And it really is an immediate reconstruction. So that's one thing that we and others are doing. The other thing that is more experimental is coming out of my research laboratory. We're investigating pharmacologic agents that have the ability to regenerate lymphatic vessels at the site of injury. And our experience has been with the use of a class of drugs called retinoic acids. These are drugs that are been used for 20 or 30 years for treatment of skin cancers as well as eczema. They've also been tried to treat certain cancers, but the mechanism of action for retinoids is that they differentiate tissue. And so they're not as good as some of the cancer killing type toxic agents. And so there's limited effects on cancer cells. So it was never really tasked to be a good chemotherapeutic, but it has a pretty robust use in dermatology for eczema and some skin cancers. And we, in our laboratory, tested a number of agents and found that retinoic acids fortuitously can drive lymphatic specific differentiation in a tissue culture dish. And then when we tried that in experimental models of mice and rats, after we gave those animals lymphedema, if we happened to give them retinoic acid at the right dose and at the right time, that induced lymphatic regeneration at the site of lymphatic injury, without the use of a microscope. It was the animal's own system being primed to do that. And since that drug helped regenerate the lymphatics, that really reduced the risk of lymphedema, at least in these animal models, to almost zero. And so that is something that we're developing and hope to bring to patients, although I suspect it will be several years before we do that due to a number of regulatory hurdles and the necessity to do some robust clinical trials. But so I think there's a lot of hope out there, and understanding that these are available hopefully will help patients that are at risk for lymphedema in the very near future.
Wow, this is really cutting edge and will be a breakthrough in lymphedema management. So we're super excited about your research, and I think it's going to give a lot of hope, to people out there, right? So, because as you said, it's you already know that this complication is going to happen. So, so pretty much if you have a way to prevent this is going to help so many people. So thank you for sharing this. This is really, really interesting. Right. So now, say if you already have lymphedema, right? So like if a patient already has lymphedema, so could you please kind of go over some of the management interventions that are currently available for lymphedema management?
Sure, happy to. And I think this is where the wound reference platform can provide and consolidate this data as it has reviewed this, and it's available online, as I think many of you know. But really, as I mentioned earlier, lymphedema is best managed by a multidisciplinary team, including lymphedema therapists, wound specialists, medical doctors, and surgeons, all familiar with the disease. And part of it depends on what are you trying to treat. If you're just trying to treat lymphedema, there's an algorithm. If you're trying to treat a wound in the context of lymphedema, that's a sort of side algorithm. But I would say that in general, the point person for management of a patient with lymphedema, they are the occupational therapists or wound specialists or physical therapists that help patients with this disease. And for mild lymphedema, the standard of care is to utilize compression garments as much as possible. Complex decongestive therapy or massage. And there's also some nighttime garments. One is called Flexi Touch, although I'm not saying that's the best one. This provides home use for lymphatic massage that can utilize sequential pneumatic compression to try and milk out the static lymphatic fluid. Other things such as leg elevation, skin care, nail care, self massage, exercise, all of these are all good things. The other thing to consider is that although we're not exactly sure why it's the case, obesity seems to be linked to lymphedema. And so in general, if a patient does have a slightly high BMI, if they are able to lose weight, then reducing weight can also have a positive effect on lymphedema. There's other things that are out there in terms of ways to manage lymphedema, such as drug therapy. I would say they're really limited, and the drugs that are potentially utilized really don't focus on a single lymphodematous limb. One medication that might be used in a very severe edematous situation would be a diuretic, and this is where you might do it because, let's say, there's blistering or the skin is just watering out. Unfortunately, that removes fluid from everywhere in the body, not just the target limb, and so it's not a great approach. But in certain instances, with an appropriate medical doctor supervision, it might be indicated once in a while. And then, of course, if there's cellulitis, then antibiotics would need to be used under the guidance of a medical doctor who treats lymphedema. And so those are the mainstays of quote unquote conservative therapy or compression therapy, as well as medical therapy. There currently is no medicine that targets lymphedema. That being said, there are clinical trials out there, and I'm involved in one led by PureTech Health. They're testing a new drug called duoprofiterone. And full disclosure, I am a site principal investigator at City of Hope for this drug. And so this targets people with stage 1 to stage 2 lymphedema. And the mechanism of action, although it's not completely known, inhibits inflammation and fibrosis that is related to progression of lymphedema. And so it is not approved today, but it is in phase 2A trials. And there might be something one day that is more focused on attacking the pathophysiology specific to lymphedema. The other things that we could talk about are surgery. Is that something you want to hear about as well?
Sure. Yes, definitely. That will be my next question.
Sure. So, I mean, as a surgeon, I like doing surgery. That being said, surgery is not for every patient. And part of, I guess, being a thoughtful surgeon is making sure that surgery is offered only to people that are going to benefit and not to everyone as a blanket therapy, because there are risks. And so I would say that surgery would be indicated in a couple of situations, and the approaches break down into a couple broad types. One would be a physiologic reconstruction of stalled or blocked lymphatics. And so this would be rerouting of the lymphatic system to allow it to flow better or flow into a lower resistance circuit. And that's called lymphatico-veno bypass or lymphatico-veno anastomosis, acronyms LVB or LVA. And this is a surgery which takes a limb and identifies lymphatics that are clogged or have a high resistance, and find an adjacent vein to provide lower resistance to. And this can be done with fairly small incisions in the arm and the leg. Different dyes and contrast agents are used to identify lymphatics in the superficial tissues. And then under a microscope, these lymphatics are rerouted to adjacent venules, which have low resistance and also valves that can prevent backflow. And so that's lymphatico-veno bypass or anastomosis. Does require microsurgery and does require specialized training for your surgeon. The other thing that can be done and is used for people with more advanced disease is called vascularized lymph node transfer. And that is a procedure where we're giving lymph nodes back to an area where lymph nodes were taken. And so this involves identifying a patient that really has done everything and is not getting anywhere. And you can transplant lymph nodes from some other part of the body to the lymphodematous area, whether it's an arm or leg or other part of the body. And this involves vascularized free tissue transfer, again, utilizes a microscope. And what happens here is at the recipient arm or leg, blood vessels are dissected out, including an artery or vein that can power the flow of a flap tissue that is transferred. And then a flap is harvested from somewhere else on the body. And this could be from the groin, from the axilla. It could be from under the mandible. It could be from inside the abdomen, such as the omentum or gastroepiploic lymph nodes. And so you're sort of robbing Peter to pay Paul, unfortunately. And there's always a risk. If you take lymph nodes from somewhere else on the body that doesn't have lymphedema, you might give that part of the body lymphedema accidentally to try and treat an area that already has lymphedema. So there's definitely risks. That being said, there are certain donor sites where the risk is very low. And there's other modalities such as reverse lymphatic mapping, which can be done intraoperatively to prevent removal of lymph nodes that are critical for drainage of a arm or limb. And so this type of therapy is something else that could be offered. When we talk about these last two surgical procedures, the latter one, this vascularized lymph node transfer, is a 6 to 8 hour surgery. And in my experience, to get this done safely requires a 4 to 6 day stay in the hospital, depending on what part of the arm or leg you're putting the flap on. And so it's a big investment. And then also you have the risk of donor site lymphatic disruption. The former procedure, LVA or LVB, is less invasive. We're not harvesting lymph nodes from somewhere else. We're just rerouting lymphatic system to a low resistance venous system, and that is done by small incisions. And generally that's a couple of hours, and I keep my patients overnight. Believe it or not, in Asia, this is done under local anesthesia, and patients just hold their arm for about an hour or two, and the microscope is there where the surgeon is doing sub-millimeter anastomoses. And in that part of the world, they can avoid general anesthesia, and patients get it done, and they probably go home the same day. And so those are the general physiologic operations. The next class of operations are considered debulking or excisional operations. And this is for patients where they're not candidates for either of the two lymphatic rerouting operations that I described previously. More advanced disease. And this is where people have patches of lymphedema where there's just chronic inflammation or infection, or generally people that have progressed towards almost elephantiasis, giant legs, where these people really can't ambulate because of the heaviness of their limb. And so this is where you would either excise part of the lymphodematous tissue and then suture the skin back together, or remove all of the lymphodematous tissue circumferentially and then replace it with a skin graft, and that's called a Charles procedure. The latter procedure is quite morbid in the aesthetics, or the look of the leg or the arm is quite suboptimal, but for patients that really can't live with their lymphodematous extremity, they are much happier because their limb is no longer heavy, and they don't have to deal with some of the complications of lymphedema. The third class would be liposuction, and this is used in conjunction with the first set of surgeries, meaning if you can correct the abnormal flow of the lymphodematous arm or leg, and then the fluid gets out and becomes softer, you may be left with some residual fat, which develops due to lymphedema. You know, adipogenesis is a side effect of lymphedema. And so while you have once you have a softer limb, then you can now suck out the fat and restore some of the contour, such that you can take someone that has a big, arm or leg due to lymphedema, then soften it up with the lymphatic physiologic rerouting, and then go back and do a liposuction to actually remove that excess fat. That would be an adjunctive procedure. These are all sort of in evolution, and it's really up to the specialist or surgeon that you see who can evaluate you independently to understand what's right for you. Lymphedema patients present in very unique ways, and it's very difficult to say, who should get what operation. And so these are customized therapies that your surgeon could offer you. And it's a conversation about risk and benefit always.
Terrific. Yeah. Wow. It's a very complex decision-making process there in order to describe, in order to choose, right? So which kind of a surgical treatment you're going to be able to offer. But, would you say that there's any particular contraindication that you say, okay, this is not a surgical candidate?
Sure. I think you always have to think about doing no harm. That's the Hippocratic Oath. And looking at patients and making sure they can safely tolerate any kind of surgery you can propose. And so, people that have prohibitive cardiac disease or pulmonary dysfunction that they would not tolerate general anesthesia, those would be relative contraindications that could be discussed with your anesthesia team. And so that would be one. Active infection, again, would not be a good time to do surgery. That kind of inflammatory response needs to settle out before you try and do surgery. Support system's important. People that don't have adequate social support to take care of their surgical wounds, whatever they may be after, again, also are not the greatest candidates. And so, I think those are some highlights. And then also, I think that people need to exhaust the so-called conservative therapies before they move to surgery. People need to be compliant with compression management and keeping their skin clean and things like that before you would offer them a higher level of care such as surgery. But it's really all integrated together. But I agree that, good questions. We need to know who could get these surgeries, who shouldn't. And again, it's really an individualized process such that it's a discussion that a patient and perhaps their therapist and perhaps surgeon could discuss and decide on who are the good candidates and who are not. It's certainly frustrating to perhaps hear that you're not a candidate for surgery, but in general, most surgeons like to operate. And if someone's telling you you're not a good candidate, it's probably because they don't want to do any harm. And so I think that there's other modalities that can be pursued if surgery is not the option.
Very good insight. Yeah. So now, for the referring physician, right? So let's say somebody thinks that they have a good candidate and they refer out to the plastic surgeon, to the specialist in lymphedema. And then, yes, it's decided that indeed the patient is a good candidate. Is there anything that the referring physician can do in order to help prep for the surgery? Any pre-op workup that could be done ahead of time?
Sure. I think the more information is always better. That being said, I don't think there's we want to be good stewards of our healthcare resources. Obviously, if someone came with a pre-anesthesia workup and a lymphoscintigraphy before I saw them, that would be great. But in some ways, if I evaluate a patient clinically and they're really just not a candidate, then you may have done a lymphoscintigraphy for no reason. And you may have, gotten a cardiac echo and pulmonary function tests for someone that really is not a surgical candidate. So I can certainly appreciate that streamlined algorithm. And I think that if in doubt, and if it's almost like if you've tried everything else and the patient's interested in surgery and you have a surgeon accessible, then it's at least worth an evaluation by a surgeon that offers the surgery. And then I wish I could say there'd be a sort of streamlined way to know, but I would say that it's so individual that I would just keep it as a multidisciplinary conversation so that everyone can make the best decision for these patients.